All right, so this was a quote that I found. I don't know who actually wrote it, but I thought it was germane to the topic. It says, "Tell me and I'll forget, show me and I may remember, involve me and I'll understand." And this is the best rationale that I can provide for the importance of behavioral rehearsal in administering CBT for psychosis. And even though I am saying that within the context of a didactic that's specific to working with people with cognitive impairment and intellectual disability, that is true for our work with clients, anywhere on the spectrum of cognitive impairment. It is critical that we're not just talking to our clients about changing their behavior or using, some new ways of thinking, but that we're actually doing it with them in session. In terms of the importance of this specific topic, we know that 3 out of 4 clients with a schizophrenia diagnosis do demonstrate global cognitive impairment and standardized cognitive assessments. And we know that we see deficits across multiple domains of cognitive functioning as early as their first episode. And there is evidence that suggests that that impairment precedes their first episode as well. The largest deficits that we tend to see are in verbal memory, as well as attention and executive functioning. And independent of that, sort of cognitive impairment, we also have this finding that traumatic brain injuries are higher among people with a psychotic disorder than in the general population. And we don't know why that is exactly. Some researchers have theorized that having a traumatic brain injury is a risk factor for developing psychosis down the road. We also know that individuals with a psychotic diagnosis, that an intellectual disability is 3 times the prevalence of psychosis in individuals with an intellectual disability is 3 times higher than in the general population. And in terms of the clinical presentation, people that have both a psychotic disorder as well as an intellectual disability may present with more negative symptoms than those who don't have ID. And we know that both the ID diagnosis and the negative symptoms both independently present challenges for treatment and for long-term prognosis. So in terms of sort of the basics around how do we treat this special population, there is some evidence that that retention in treatment and that response to treatment is worse among individuals with higher levels of cognitive impairment. So clearly that means that we need to be more focused on specialized interventions for this population and specialized engagement strategies for this population. And I hope that this didactic does an adequate job of touching on both of those. But I do want to say that there is not a lot out on the literature on this topic, and particularly around adaptations to the intervention for these special populations, despite the fact that that cognitive impairment is, so common in this population that, 75% are going to be struggling with some level of cognitive impairment. What modifications to CBTP that we do find in the literature tend to relate to practical application rather than theory. So that's good for us, right? We can still use the same empirically supported theories, but we're going to want to make some changes to the way that we are teaching people skills. And just a general note before we start diving into techniques is that having at least a general sense of the client's neurocognitive functioning should be part of the formulation, right? We think about that formulation, that case formulation, as really just being a robust assessment of the person's risk and protective factors and how those are combining to exacerbate somebody's distress or to keep them in an impaired state. And we are particularly attuned in CBT to the perpetuating factors, right? The things that are still ongoing right now that are acting as barriers to the person's goals and to their functioning. The other way that this is going to manifest in terms of our case formulation is that more than 60% of people with ID experience severe trauma, right? So trauma history, we know in general among people with psychosis is more common than it is than the general population without psychosis. And here we have another risk factor for that trauma history if they have an intellectual disability, and thinking about trauma broadly, right? So thinking about being bullied for ID, being restricted from school, being told that, being called names about your abilities, or the fact that you're living at home after the age of 18. So we want to be attuned to that as we're getting to know the person. So first step is assessing capacity for CBTP, and that's what the demonstration that we're going to be showing after the video, or after the didactic, will hopefully be helpful for. But in general, this guidance comes from the Dagnan article, which is one of the 3 articles that Jen sent before the clinic. And we need to be thinking about the person's ability to identify and differentiate emotions. And it doesn't mean that they need to be able to label, X number of emotions, but we want to give them, that kind of emotion chart with the different faces, and we would like to see how many different emotions can they identify, and get kind of some sense of emotional literacy, the ability to link an emotional response to an activating event, and then the ability to recognize how thoughts shape the emotion. And I'll talk more about that. The Dagnan article provides some suggestions about how to assess that. And then Frontier Behavioral Health and our team worked together to put the assessment together that Stephanie will be demonstrating. It's so important that we are simplifying our language as much as possible. And so here is an example of what the cognitive triangle might look like. Now, you'll notice in the box on the left, we're talking about negative, automatic negative thoughts, which we call ants, and then we've got the visual of the ants, and we've got all of the steps, right? The thought, the feeling on the bottom left, and then the behavior on the bottom right. And we're showing with those arrows how each of these is connected and how they go into a cycle. And then any of you guys who have been trained by me, which is actually everybody on this call, knows that one of my pet peeves is thinking about CBT as simply positive thinking, right? It's the Stuart Smalley approach, where we just kind of convince ourselves that the opposite of our automatic negative thoughts is true. Clearly, that's not the case. We're going for more balanced and more helpful thoughts, but with our need to be more concrete and simplistic in explaining these concepts to folks with ID or severe cognitive impairment, it is actually helpful to use a much more concrete, if reductive kind of explanation. So replacing that I'm stupid thought with an I can do this thought. And then related to this simplifying guidance is also the guidance to avoid use of metaphors, to avoid these abstract kinds of ideas, to be as concrete as possible, using examples that you either know that the person will be able to relate to. So I'm going to give an example of what happened on the bus because I know they take the bus. And trying to minimize people kind of getting caught up in the very specific things that you're saying. Like if you're giving a metaphor, they're gonna take that literally. All right, broad and general techniques. It is important for all of our folks that we're involving family members and caregivers. It's, I would say, critical and to the effective execution of the intervention to bring families and carers in this case. Consider if it's possible to change the structure of the session. So you're administering 1 or 2 30-minute sessions per week. being flexible, being responsive, and being attentive to cognitive fatigue. I remember when I was a new mom, I'm kind of semi-competent in another language, and I took my toddler to a play group that was with parents that were speaking that other language. You know, everything was in the other language, and it was a 30-minute play group, and I was exhausted by the end of it because my brain was really working overtime. So we really need to anticipate that people are going to be working hard in these sessions and shorten the duration of the sessions and make it more frequent to help with that information processing, retention, and energy. We know the pace of the session and the treatment is going to be slower, and it needs to be more focused. So we need to get a very clear picture of what are our specific treatment targets. We want to give the person more information or sort of another model of thinking about their experiences or their symptoms. Obviously, to help that process of reattribution, right? So they're thinking about my symptoms mean this or come from here, and we want to give them one clear alternative explanation for their symptoms that's going to be more therapeutic for them. And we want to reduce distress associated with the voices and increase stress management skills. Those are really good targets for a lot of folks that hear voices. It's common, when we work with other folks without severe or moderate cognitive impairment, that we'll get a lot of bang for our buck with our skills. Typically, by the time we're in relapse prevention phase, our clients are seeing the benefit of these skills, not just for one specific problem like hearing voices, but also for helping them get to sleep, for regulating anger, for helping them be more effective in a conversation. That's not as likely to happen because it's not as easy for our folks with ID or cognitive impairment to generalize the skills without explicitly kind of being told and being walked through how it would be applied to those other situations. We want to assess carefully for environmental stressors that might be contributing. And this is one, again, this is good practice in general, but especially important for our folks with ID because they may not recognize that things are impacting their behavior, impacting the way they're thinking about things, impacting their sleep. So as an example, I had somebody who didn't tell me that he wasn't getting good sleep. He told me he wasn't sleeping well, but didn't tell me that he was being woken up by the person who ran his group home in the middle of the night and being taken to another group home that she was also managing and made to sleep in an armchair because he didn't want to get her in trouble and he didn't actually think it was a problem. So that was something that came through a series of questions to elicit that. And then finally, spending more time engaging the client and providing explanation in simple terms that the client can remember. So behavioral activation, I use my mantra over and over and over again. The more you do, the better you feel, because I want to drill that mantra into their head. That they're more likely to remember that mantra than a lengthier explanation of why we're asking them to get activated. It's critically important that we're assessing for their ability to make the link between the situation, thoughts, feelings, and behaviors as early as possible to determine goodness of fit. And so think about in that introductory session where we're just getting to know each other and talking about the cognitive model, you are going to be explaining it, and then ask for that teach back. Ask for them to give you an example of something that might have come up for them that was a situation that led to them feeling maybe annoyed or frustrated, and see if they're able to do that, and then work to complete all the elements of the triangle themselves. Oftentimes, obviously our default mode as a cognitive therapist is Socratic, open-ended questions. For our folks, for this population, we really want to ask more closed-ended questions. So when you use that skill, when you use the paced breathing, did you notice that you felt better or worse? Rather than tell me how you felt when and then we want to balance that too with this acquiescent style where the person really just wants to please you, and so they're saying yes to everything. You will likely need to be more directive, and you're certainly, I mentioned this earlier, going to want to be extremely concrete. So writing a list of 3 things that the client will do when they're disturbed by the voices, so that they've got that card in their pocket or written on their phone or on a Post-it note by their bedside table. And whenever possible, demonstrate in session first. So making sure that you're doing it with the session or with them in session, that you're engaging. If you have the luxury of having peer specialists on your team, I know our ESA providers have occupational therapists on some of their teams, really leveraging other members of the clinical team to help the person engage in these new behaviors and remind them of the cognitive model and empower them to shift that thought to something that's more helpful. Making sure that we're communicating action plans and homework to support, to enlist help and increase accountability. So bringing in a loved one at the end, last 10 minutes of every session. So-and-so, can you share what you learned today about X? Can you share what we did today? Again, good practice, but critical for this special population. And if you don't have the luxury of having a loved one there in person live, then call them on the phone for those last 10 minutes. Make ample use of pictures, video, writing. Multimodal learning is going to be best. Making sure that they're really getting it, something will click for them. A lot of the worksheets that we borrow from the Kingdon and Turkington materials are likely to be inappropriate for these clients. A lot of them have a lot of writing on the page, terms, even our making sense document can be really challenging, as well as the 5 steps of CR that might be challenging for them. And so we want to make sure that we are making adaptations for them whenever possible. And I'll talk about one adaptation to the 5 steps of CR in just a minute. Lots of repetition. So we're going to set our agenda, which is going to be very clear, very concise, and very brief, right? We're probably going to have about 3 things on the agenda, including checking in on home practice. Then we're doing those midpoint summaries, and then we're going to be doing our endpoint summary. And we're using a lot of Socratic questions to check for understanding. We're getting teachbacks from them, asking for examples, asking for loved ones to give examples. And then if it is possible for you to go to them so that the client is practicing new skills in their environments, that's going to be really optimal because that will facilitate the generalization. For cognitive interventions, I think one of the steps that for many of our clients is really, really helpful is identifying cognitive distortions. For our clients with ID, that can be very, very challenging for them to do it. And so I would say that's the first thing that gets cut, right, from cognitive restructuring, is asking them to pinpoint a cognitive distortion. And if that's controversial, I'd love to hear other thoughts on that. But I find that CR can still be effective without labeling the thinking styles. Make sure you've got, so guide to thoughts and feelings is very, very helpful for this population. If that one is unfamiliar to you, if you haven't used that one since you were trained, it's in your binders, it's in your online repositories, check it out. Because it helps people work backwards from the emotion to identify the thoughts. Make sure you've got that emotion chart handy with you on the board, on a poster, and draw the cognitive triangle, and then reduce the number of open-ended questions. So you're going to lead the client. So I wonder when let's say you're asking the client, they went to a party and they left. And you're trying to get at the feeling and the thought. So they identify the feeling as just, I felt unhappy, let's say. And then you want to say, okay, were you feeling unhappy because you thought everybody would talk to you? Or were you feeling unhappy because you thought, maybe no one would talk to you? Because you have a general idea that's probably what was going on based on your formulation, other context clues. And then they say, no, I didn't think anybody would talk to me. Okay, so now you've got a thought. without asking that open-ended question that they find challenging to respond to. There's a fantastic article that we have sent around in the past, but didn't this time. The lead author is Paul Grant. Aaron Beck is also on the paper, and it describes recovery-oriented cognitive therapy for an individual they call Mary, a 72-year-old woman being treated as an outpatient with severe cognitive impairment, and they use catch it, check it, change it instead of the 5 steps of CR. It's very concrete. They literally write the thought on a piece of paper, they crumple it up, she catches the thought, and it describes how they prompt for changing the thought and checking the thought and changing the thought. So if that's of interest to you, it should be in your online repositories. We'll make sure that it is. And then the last thing with regard to cognitive interventions is for a lot of our folks, just having that positive coping statement can have a big impact. So that's what we might call a cognitive reframe versus a cognitive, restructured thought. Is they didn't go through the process of checking the evidence. That would make it a restructured thought, but they do have a more positive frame on the situation. And so having them write it down, having them rehearse saying the thought in the mirror or in the, on the bus, and having those visual cues can be very helpful. For behavioral interventions, we want to assess logistical barriers with planning that looks a lot like the kind of behavioral tailoring approaches that we use for remembering medications, and that can include text messages. That could, if you have a policy that allows you to text message your clients, you can send them some prompts during the day, or you can set it up so that loved ones set up supportive prompts throughout the day, or supportive calls or reminder calls, coordinating with other people. All of that is not only acceptable, but indicated. Helping them to organize. And if there's a case manager on your team, then case managers can be incredibly helpful with these planning and organizational interventions. For helping with deficits to attention and concentration, short assignments that provide quick relief, right? And remembering that learning occurs best in the moment. So if you can have the client do that thing with you in session and then ask them that important follow-up question, did you feel better or worse? If given that it made you feel better, what might you do the next time, you're feeling unhappy or whatever? Or what does it say about you that you were able to do this new thing? Behavioral experiments along those same lines can have a big impact on a belief because you're actually getting them to test it out. Your setup and debrief are probably going to be a little bit less explicit maybe than they would otherwise. And then you're not going to be able to accomplish as many interventions in the same amount of time because you need to go slower and you need to have shorter sessions. And so hone in on a few powerful interventions and use those. So, we've got a smaller list of treatment targets and we have a smaller list of interventions, but we think that these are really high yield interventions for this person. And then look for opportunities to build skills in particularly distress tolerance, social, oftentimes their social network is in tatters, physical activity, distraction and refocusing attention, and then anything that's goal-oriented behavior.